You're listening to Medscape's In Discussion series on systemic lupus erythematosus, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Maureen McMahon. Dr. McMahon is a professor of medicine and associate chief of rheumatology at the David Geffen School of Medicine at UCLA. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Maureen McMahon. Welcome to the Medscape In Discussion podcast series on systemic lupus erythematosus. Today, we'll discuss lupus nephritis with our guest, Dr. Brad Rovin. Dr. Rovin specializes in autoimmune kidney disease and is the Lee A. Herbert Distinguished Professor of Nephrology at The Ohio State University Wexner Medical Center. Welcome to the Medscape In Discussion podcast.
Thanks, Maureen. It's a real pleasure to be here. And as you know, love talking about lupus nephritis.
And I love listening to you talk about it. I think that we've had a lot of new guidelines for the treatment of lupus nephritis in the last several years. So I wanted to just kind of first get your take. I know we have the new ACR lupus nephritis guideline. They're a little bit different from the KDIGO guidelines that were released and the EULAR guidelines. And so I just wanted to kind of get your impression of what those guidelines are, maybe review for everybody some of the high points and your takeaways from how you're using that in your practice.
I work directly with KDIGO on glomerular disease guidelines, so I had a hand in that. And I also had a hand in the ACR guidelines, participating on the work group. Those are the two I'm most knowledgeable about. And the EULAR guidelines, the new ones are being developed. The first thing I'd like to say is, as a guideline person for many years, one of the worst things we could do is have guidelines that contradict each other. Now, the KDIGOs came along first, and then we updated them in 2024 because 2 new drugs had been approved. Our guideline came out prior to that. And so we really wanted to put in voclosporin calcineurin inhibitors as well as belimumab. Our guideline in KDIGO was sort of interesting. It gave a menu of therapies that you could choose from, and that included what we tend to call, and maybe it's not the best name, dual therapies. I don't know what you like to call these, but when I think of a dual therapy, I think of cyclophosphamide, and in the KDIGO guidelines, we suggested urolupus or low dose, plus glucocorticoid, or mycophenolate plus glucocorticoid. So those are dual therapies. And then the triple therapies are those background therapies and then something else added to that. And that could be most often a biologic or the calcineurin inhibitor. And so we gave sort of equal weight to all of the therapies. What I think innovative or difference in the ACR guidelines, and we had a lot of discussion around this, is that in the ACR guidelines, we push the idea that triple therapy, if it's available, is really the way one should to start treatment with lupus nephritis.
I was going to ask if you're finding in your practice that you really are starting with triple therapy in most patients right away.
Yeah, so that's really an important question. And what I'm doing and my group, obviously my group are nephrologists.
Right.
And so we tend to be very comfortable with calcineurin inhibitors. And so we actually have been using triple therapy for a really long period of time with a calcineurin inhibitor plus mycophenolate plus glucocorticoid. Most often, occasionally we will use the urolupus cyclophosphamide plus something else. And that's okay. And I know, just for everyone who's listening, in the Aurora studies that the calcineurin inhibitors or voclosporin was approved, we did not have an arm with a background of cyclophosphamide.
Right.
So we have been doing that. My reasoning is that I like to get proteinuria under control as quickly as possible. Proteinuria in and of itself, large amounts of proteinuria can be harmful to the kidney by setting up tubulointerstitial damage through inflammation initially. And of course, damaging the tubulointerstitium of the kidney leads to progressive kidney decline over time. It correlates very well with the loss of kidney function. So I like to get that underway very quickly. I'm also a podocyte protector, if you will.
Right.
If everyone goes back to their days of the anatomy of the glomeruli, the podocyte is a really important cell for maintaining glomerular filtration barrier. The way I think about it is when you have active immune complexes accumulating in the kidney, it's likely that this is where podocytes are being damaged. And the nice thing about voclosporin and the calcineurin inhibitors is that they're podocyte protective. And once you lose podocytes, it's really not clear that they regenerate. That's a big
Hmm.
area of research in nephrology. And there's some indication maybe some of the maybe parietal epithelial cells could transform. But the word on the street, if you will, is if the podocyte is gone, it's gone. And if you lose too many podocytes, then even if you stop the disease that initiated the problem, that nephron will be lost and will eventually just scar down. So you lose too many nephrons, obviously, your kidneys have trouble. When I talk to my rheumatology friends, and I'd be interested in what you say, they don't like the calcineurin inhibitors because someone told me that they're afraid of them. And I said, why? And I think calcineurin inhibitors carry a reputation of causing changes in GFR and rise in creatinine
Right.
and also damage to the kidney from the transplant literature. Do you use calcineurin inhibitors?
So I do, and I have to admit that I have had the same bias initially. I was always a little bit wary of the calcineurin inhibitors, and I'd seen some hypertension in my patients, one starting, et cetera, that I had to manage. But I do have to say that in recent years, I've become more and more comfortable with the calcineurin inhibitors, and I'm much more likely to use it. I think one of the things that I struggle with a little bit with my patients, especially these brand new diagnosis of lupus nephritis or even a brand new diagnosis of lupus, is the pill burden. And I was wondering how you talk to your patients about that, or if you have any tricks or tips for dealing with that.
Well, the pill burden is something that is astronomical when we add the calcineurin inhibitors, especially for those of us who have access to voclosporin, that's 6 extra pills a day.
Right.
And we have talked about the need for a bigger size pill.
Right.
I actually think, and I know what you're getting at, which is these are by and large young people who were healthy before all this, and nobody wants to take any pills a day, let alone 20 pills a day. That leads to issues with adherence. Of course, to me, adherence is my number one reason why people appear to have refractory disease because they're not taking the medicine the way it's prescribed. I used to be able to check calcineurin levels very readily when I was using tacrolimus or cyclosporin. I don't use cyclosporin very much anymore. I do occasionally use tacrolimus. I can check levels to understand if a patient is taking the medication. Can't do that with voclosporin. I don't have any particular tricks. I go over the reasons why. And in that sense, I realize the belimumab option might sometimes be quite useful.
Right.
Intravenous is once a month, and you sort of know what's going in when the patient comes to the infusion center. So like you, I'm getting more and more used to belimumab
Right.
over the several years because I hadn't been using it before. I think you pointed out a really important thing. We have to work with them so that we get comfortable in using them. I do think, however, that this issue of adherence and pill burden is really something that we have to tackle as a community, working with pharma to make sure we can get these medications and formulations that are easy for the patients to take.
Yeah, I agree. And I do actually find, kind of going back to the guidelines, that it's actually been helpful for me in my conversations with patients to be able to say, these are the guidelines. This is why we're recommending that you have all of these different therapies. Seems like a lot right from the start, but this is kind of the common standard recommended practice. So that seems to have given some reassurance to patients.
The other thing I think is reassuring, and I do tell my patients because, when they see the initial, Usually there's a steroid that's being tapered, and there's mycophenolate that's more than usually one pill a day, and then a voclosporin or a calcineurin inhibitor or belimumab. I do tell them that over time, my goal is to wean off the medications so that this idea that they're going to be on this number of medications is for a period of time, but not forever.
Right. A little bit of a light at the end of the tunnel for them.
I think so. Exactly right.
Yeah. The other thing that I've found in recent years that's been helpful is that we're really using less steroids, I think, than we did when I started practicing. At least we can say, hey, we're trying to minimize steroids and their complications. But I'm curious what your thoughts are on steroid use and how that's kind of evolved.
My steroid use has evolved considerably. I think that's good that, I sort of adapt as things change. But when I started out, we were using very large doses of methylprednisolone right up front.
Right.
When you go back, we certainly use large doses of methylprednisolone in transplantation. And I don't know how we started those 1 gram times 3 days. It seems like this is traditional medicine, and that's the way we did things. And then I started at 1 milligram per kilo per day of oral prednisone. And yes, I saw many, many steroid side effects. Since the voclosporin trials really pointed out that we probably don't need as much. And then the more I understand steroids and the more I understand what they're doing, I think the important thing is defining what are you using the medication for? I am using glucocorticoids to control inflammation right now. And I think Liz Lightstone has done some beautiful work from the UK. We're varying a little bit away from the guideline, but that's okay. She treats her lupus nephritis patients with a combination of mycophenolate plus rituximab, and then just has 1 gram of methylprednisolone during the rituximab infusions, 500 and 500 milligrams. About 1 gram of methylprednisolone is probably enough to control inflammation very quickly and allow the other drugs that will control the autoimmunity to start working. And that, to me, is what we need. We need to give the kidney a little bit of time, get the inflammation under control, because that's causing damage right now that will result in chronic damage, scarring. But then if you can start to control the autoimmunity, the inflammation will go down because you're not depositing immune complexes anymore and inciting inflammation. So to me, using a smaller dose of upfront intravenous glucocorticoid allows me to control inflammation, and then I can start out at a much lower dose. I haven't been brave enough in most cases to
To use none.
use none and to really even get down to the voclosporin equivalent in the Aurora trials. Well, it was about 0.3 milligram per
Right,
kilo per day.
Right.
I start out a little bit more conservatively at 0.5 milligram per kilo per day, but then taper down fairly rapidly. And I would say that our guidelines in KDIGO gave a whole range of glucocorticoid dosing. The ACR guidelines were really favoring 0.5 or lower. Both guidelines suggest really coming down on the steroids very, very quickly and allowing the other drugs to do what they do.
Well, let me ask you another question along the same lines. Certainly, we're all, I think, learning to be more aggressive with treating nephritis and not allowing patients to linger for a long time with only a partial remission or not getting down to the levels we want. But on the flip side, how quickly do you see, or how long do you let patients go on the same treatment before you feel like you need to switch or you need to do something different?
Yeah, both KDIGO and the ACR guidelines are with the idea that we should start to see something within the first 3 months of treatment. And ideally, we would like to see urine protein to creatinine ratio or proteinuria drop by about 25% in those first couple to 3 months. We also want to know that the systemic disease is being controlled. I mean, I think a lot of folks, nephrologists maybe, think about, well, it's the kidney and nothing else is going on, but you well know that there's a lot of other things going on. So we like to see the complements improving if they were hypocomplementemic and the serology, the double-stranded DNA declining. So I look for all of those things, but maybe the most important is the change in proteinuria. And we really start to seriously consider changing therapy to an alternative first-line therapy if we don't see a decline of at least 25% in the protein. I know it's obvious, but I'm going to say it just to be clear. If patients are getting worse on the therapy you're giving them, I don't wait 3 months. Sometimes when you give high-dose glucocorticoid, it has two effects. You can affect the muscle, and so the creatinine can go up, but it can also increase GFR. Creatinine can go down. Creatinine is a little bit wobbly at the beginning. I don't panic initially, but if proteinuria keeps getting worse and you trend that out, something is wrong. I do make sure they're actually taking and getting the medications, but beyond that, then I consider, changing.
One of the other things that I've learned from you is to not fear renal biopsies. Do you want to talk a little bit about when you use renal biopsies, both initially and also how you use them when you're thinking about withdrawing therapy?
Yeah. So I think the kidney biopsy has a bad reputation because it's an invasive procedure. And certainly I absolutely understand that. But on the other hand, over the many years I've been practicing as a nephrologist, the safety of the procedure has improved dramatically. Remember, we used to keep patients inpatient after a kidney biopsy. Now it's an outpatient procedure. The needles have become automated. The skills have been much better in terms of visualizing the kidney with ultrasound or CT scan. So I think biopsies can be done safely. There's a lot of data out there analyzing the safety of biopsies. Most patients want to know what they have, and the initial biopsy at diagnosis to me is really important. It's pretty clear that a patient has a diagnosis of lupus nephritis if they develop proteinuria and hematuria when they have a diagnosis of lupus. However, you don't know what they have, and looking at the kidney, you can be surprised. And I'm not necessarily a big fan of the classes of lupus nephritis, the way we categorize them. I'm a much bigger fan of looking at the chronic damage when I see the kidney and looking at the acute damage, so I understand how aggressive I have to be in my therapy and what I can expect as the outcome. Let me explain that a little bit more, because a very famous nephropathologist said if you're going to do any biopsy for lupus nephritis, do the second biopsy, which was a little tongue-in-cheek, but it was important because the delta between biopsies tells you how the patient is probably going to do. But in lieu of that, the importance of doing the first biopsy is to get a feel for how much damage has accumulated and how inflamed the kidney is. The inflammation is relevant because that's reversible, and that's what we're targeting with all of our therapies to, one, control inflammation and then control the autoimmunity that caused the inflammation. The other side of the coin is a lot of our patients come in and they already have damage to the kidney because the diagnosis of lupus nephritis is often made after proteinuria has achieved a certain level. Several of our rheumatology colleagues and I are working on a project to figure out about how can we tell if a person has early lupus nephritis. Can we intervene much before the proteinuria is over 500 milligrams or a gram a day? And if we do that, can we then have treatments that are more effective to preserve more kidney parenchyma? So that's why I do the first biopsy. The other thing is thrombotic elements are not uncommon in patients with antiphospholipid antibodies, and that requires a different treatment. Often we use anticoagulation if we see microthrombi in the glomerular capillaries. And sometimes you can get fooled. Something else is present, a lot of proteinuria, and the patient could have simply class 2 lupus nephritis with a lupus podocytopathy, which is much like minimal change disease that we see in children and adults. Once you've got lupus nephritis going, the second biopsy after you're thinking about withdrawing therapy can be quite helpful. We found that when we're thinking about patients who've done really well and all of their clinical parameters are good, about 25 to up to 40% still have active lesions of the kidney. The most common active lesion that I think about is glomerular hypercellularity, which is inflammatory lesion, and the capillaries fill up with inflammatory cells. And while it improves over time, if it doesn't go away, it's highly associated with flare down the road if you remove immunosuppression. And so that would be an indication to keep going with immunosuppression, even if the clinical attributes have improved greatly and you wanted to withdraw immunosuppression. By the same token, we find that a reasonably large percentage of patients who have ongoing proteinuria do so because they've accrued chronic damage with nephron loss. Chronic damage with nephron loss leads to leaking of protein, and that can fool you. And so you can't distinguish this currently based on simply serologic examination or clinical findings. I think we're close to having biomarkers to distinguish that. That field has moved forward very nicely. For now, a biopsy could tell you whether you need to continue therapy or you could safely remove therapy. And certainly in a patient who has ongoing low-level proteinuria, it's nice to know that that's not due to active disease, because you don't want to overtreat someone with immunosuppression if they can come off or down dramatically.
Yeah, I think that's a really important point. And again, giving patients hope for when they can finally withdraw therapy, in some cases. I know we're running low on time, but I just wanted to get a real quick insight into what you think are the most promising treatments on the horizon that we should look forward to.
This past weekend, the Regency trial data, which was the phase 3 trial for obinutuzumab plus mycophenolate plus glucocorticoid versus placebo plus mycophenolate plus glucocorticoid. The publication came out in the New England Journal, and the readers can look at that, but that trial met its primary endpoint. There was a significant improvement in complete renal responses at week 76 with obinutuzumab. So this gives us our first approval of an anti-CD20 agent, our first positive trial. I'm getting ahead of myself. Hopefully this will lead to approval so we can have access to that medication. And I know a lot of people have been using rituximab off-label, but obinutuzumab, in my hands anyway, and many others, is much more potent and very, very effective. So that's exciting news. The anifrolumab trial is moving along nicely, and so we might know soon whether or not we might have an anti-interferon agent available for the treatment of lupus nephritis. Some of the really exciting developments over the last couple of years have been this idea of cell therapies in lupus nephritis. Now, none of those trials are finished yet, and the data are emerging slowly. This is an opportunity perhaps to have patients really have long-term therapy, a long-term response to therapy without the addition of immunosuppression over time. I'll tell you one thing that I think is really exciting is the bispecific antibodies, because they seem to reproduce what's happening with the cell therapies, the CAR T cells, without all of the preconditioning. Now, it isn't clear to me that you can be free of all treatment at the end of the specific therapies, but these are just coming under trial. All we have now are case reports, but those case reports are very exciting. So I would say if you were to ask me several years ago when I started doing clinical trials and everyone for lupus nephritis failed, I thought, oh my God, I'm a disaster for these things. But now I'm so excited because I'll just bring this back to our first conversation. I, as a guideline developer, feel I will be revising the guidelines on almost a yearly basis under the KDIGO umbrella, because I think new therapies are going to be coming down the pipe that frequently to help our patients.
I think that's really exciting. Today, we've been talking with Dr. Rovin about lupus nephritis. We have covered the guidelines and the push to be using more aggressive therapy in our lupus patients so that we can prevent long-term damage. And again, we're doing that on the background of trying to use lower glucocorticoid doses so that, again, we can prevent all the damage that is associated with those medications. Thank you so much, Dr. Rovin.
Thanks for listening to Medscape's In Discussion Systemic Lupus Erythematosus podcast series with our host, Dr. Maureen McMahon. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on systemic lupus erythematosus.